Dear colleagues, my name is Alessandra Gennari. I am a medical oncologist from the University of Piemonte Orientale in Novara, Italy, and I'm also the head of the Division of Oncology at Maggiore University Hospital in Novara, in Italy, of course. I am also, as you may know, the first author of the Metastatic Breast Cancer Guidelines of the ESMO Society. And for this reason, being here in ESMO 22 in Paris, I thought it would be useful for us to discuss about two trials that have been presented yesterday in the metastatic breast cancer session that will probably have an impact also, at least one of them, on the update of our guidelines. The first study is the Monarch 3 trial. The Monarch 3 trial is a study comparing the addition of abemaciclib to first-line endocrine therapy with an aromatase inhibitor, letrozole, versus single-agent aromatase inhibitor therapy in endocrine-sensitive metastatic breast cancer. Here they presented the overall survival data from this trial. Overall, there was a median survival of 67 months for the combination of abemaciclib and letrozole versus letrozole, with a survival benefit exceeding 12 months versus single-agent endocrine therapy. This difference did not satisfy the statistical requirements for significant improvement according to the trial protocol. However, you would agree with me that a 12-month survival benefit in the metastatic breast cancer setting first line is an important clinical benefit, and we cannot simply discard it as not significant. It is an important benefit in this particular patient population, where we have also important benefits from the use of ribociclib from the Mona Lisa 2 trial. So the other important trial that will probably have an impact on the update of the metastatic breast cancer guidelines is the TROPiCS-2 trial. The TROPiCS-2 trial compared the use of an antibody-drug conjugate of sacituzumab govitecan in the treatment of endocrine receptor positive but endocrine resistant metastatic breast cancer patients pretreated with other chemotherapy and endocrine therapy-based regimens. In these particular populations, there was a statistically significant survival benefit for the use of sacituzumab versus other chemotherapy regimens, including capecitabine, gemcitabine, and eribulin, according to standard clinical practice. As a matter of fact, median progression-free survival in this heavily pretreated population was 14.4 months with sacituzumab versus 12 months, 12.2 months with conventional chemotherapy. These results are very important since they may have an impact in clinical practice and they may also have an impact on the updates of the treatment for endocrine receptor positive heavily pretreated metastatic breast cancer. Now we have two treatment options other than chemotherapy in this patient population after having explored all the endocrine related pathway, including CDK4/6, alpelisib, SERD, or whatever. We now have two options. We have deruxtecan after the results of the Destiny Breast 04 trial in the HER2-low patient population, and now we have also sacituzumab in the overall ER-positive metastatic breast cancer population heavily pretreated for metastatic disease. So I think these two trials needed to be highlighted because they're going to change the clinical practice in some measure, especially the TROPiCS-02 trial. I'm sure that we will have soon the possibility to use sacituzumab also in this patient population. Thank you very much for your attention.